Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Manic Community Health Center for hosting today's session, Cardiovascular Risk Factors and Lifestyle Modification with Dr. Robert Master. Robert C. Master, MD, FACC, is currently an adjunct clinical associate professor in the Department of Medicine at Stanford University School of Medicine, where he focuses on teaching the next generation of physicians about bedside medicine, critical thinking, and the art of diagnosis, practicum of medicine. For over 30 years, he was an interventional cardiologist in a large multi-specialty group with a practice that spanned from general cardiology to imaging, echocardiography, nuclear cardiology, CTA, EKG, including treadmills, polar monitoring, etc. This also includes pacemaker and AICD implantation, in addition to invasive angiography and coronary interventions. Dr. Master's areas of expertise extend to all topics of general cardiology. And with that, Dr. Master, we will start. Let me just share my screen and I will get the presentation going.
Jennifer, thank you for that kind introduction. So please, if you have questions during the presentation, don't hesitate to either put them in the chat or raise your hand. And then at the end, I'll leave enough time so that any questions that you might have, hopefully I'll be able to answer. So one of the critiques of modern medicine is that we're focused on disease rather than health. And there is some validity to that critique, but I think it's complicated. And part of that critique has to do with the fact that, and I hope that what this presentation shows, that rather than being in conflict, the idea that we're focused on both disease and health are not in conflict, but rather synergistic. That we can approach both sides of the problem at the same time. We can chew gum and walk, as they say. And, I think one of the reasons that it's so difficult is that to make changes is that lifestyle is a habit, and it's very challenging to change any habit. So when I hear people say that physicians don't talk to patients about optimal health, I would say I used to talk to people every day about things that they should do, but they were often highly resistant, I don't think on a conscious level, but the way you eat, the way you exercise, whether you smoke or not, that's so ingrained in people on a variety of levels that it is very difficult to change. And I will say, as an interventionalist, I was trained to intervene on disease, but then when I would see my patients more as a primary cardiologist, I would focus on lifestyle. However, it's very different in that your outcomes, for example, as an interventionalist, like putting in a stent, is, oh, someone doesn't have chest pain. When you are counseling someone about lifestyle and they make changes, basically the outcome is a non-outcome in the sense that really nothing happens. The patient is healthy, which is a non-event for the doctor and the patient. And it's really, if you think about it, that's exactly what we want. But it's a different way of thinking about what we're doing. Now, I'm going to paraphrase an old Chinese proverb that says that the wisest and superior physician prevents disease. A mediocre provider treats impending disease, and an inferior physician or provider treats disease. So today we're going to focus on lifestyle interventions, how to avoid being a cardiovascular statistics, and how to make changes to change your risk profile. So let's go to the next slide. And we'll just deal with disclosures. I have nothing to disclose. Next slide says basically this is accredited for one CME. Next slide. So as a cardiologist, my focus in terms of health is on cardiovascular disease prevention. And it was interesting. I was trying to tease out from the literature what percentage of heart problems are nature versus nurture. That is, what percentage of events can be prevented by adopting a healthy lifestyle versus our nature, our genetic makeup in which this is preordained. And it was interesting to see there was quite a spectrum of answers to that, anywhere from 15% to 90%. But I think the bottom line is that most interventions are most effective when you intervene on several things at the same time. So it's not just a matter of addressing someone's exercise level or their blood pressure, their cholesterol. It's about intervening on all those. And just like we know risk factors are additive, we know that addressing risk factors are subtractive in the sense that, so if someone has 3 risk factors, they have roughly 8-fold the risk of someone who doesn't have any. But if you do that in reverse, there's also a significant benefit in intervening on several things at the same time. So cardiovascular disease, which includes both heart and brain problems, it causes about 25% of deaths worldwide. And this is the most common cause of death among men and women across the entire planet. And as a woman, you might think, oh, what about breast cancer? Well, 6 times as many people die from heart problems as breast cancer. So even though breast cancer affects 1 in 6 women, cardiovascular disease is a much bigger problem. In the United States, roughly 800,000 people die every year, 200,000 under age 60. So you would have to say that's premature. Now, in this one article I read, it said 125,000 of those deaths were preventable with risk factor modification. But I would say that that is purely an arbitrary number, and people disagree quite a bit about that. And as we'll talk about, the goal is not just primary prevention, but to also secondary prevention to alter the course of the disease. In the United States, about 250,000 people die suddenly, half under the age of 65. So a lot of these people who die, really, there is no prodromal symptoms that herald the fact that there's anything wrong. Next slide. So what are we trying to prevent? We're trying to prevent atherosclerosis. In lay terms, this is known as hardening of the arteries, mainly because there's some calcium, but it's a little bit more complicated than that. Atherosclerosis has to do with plaque. And if you look at that plaque, you'll see lipid accumulation, inflammation, scar tissue, calcium, and acutely clot. And this can involve the coronary blood vessels, so it can cause angina, sudden cardiac death, myocardial infarction. Cerebral blood vessels can cause stroke or TIAs, abdominal, where it can cause abdominal angina, and lower extremity vessels, where it causes peripheral vascular disease, and amputation and claudication can involve the aorta and cause aortic aneurysm, and of course, death, as well as heart failure. Next slide. So these are all the things we're trying to prevent. We're trying to prevent events from occurring. In someone who's had an event, we're trying to prevent a second event and slow disease progression. And lastly, and I think this is important, a number of these risk factors need to be addressed with drugs. And as people get older, they're often taking several medicines. And what we're trying to do is get people to adhere to taking their medicines. And part of that is educating people both about potential side effects, the importance of taking their medicine, and making sure that the treatment that we have selected is optimal, meaning it's effective, affordable, and lastly, sustainable. That is, people will continue to take it, because a significant number of people who start medications stop taking them after a period of time for a variety of reasons. And I think it's very important, as care providers, not to be judgmental about this, but try to understand when someone stops a drug, it may be just that they thought, well, when their prescription is over, that they don't have to take the pills anymore. Or it may be that they think that there's a side effect that in fact has nothing to do with the medication. So it's very important, the benefits, for example, of statins are only among people who take them on a fairly regular basis. If people take them irregularly or they don't take them, they don't get the same benefit. Same is true of blood pressure medicine. So we have to be aware of the fact that compliance with what we put patients on is not a given by any means. Next slide. So there are certain risk factors that are modifiable and some that are not. And so some of this is sort of nature versus nurture things. So the things that you can't change is you can't change your age. And age is probably one of the biggest risk factors for disease, because obviously disease increases with age. And if you look at the risk calculators, age is always one of the things that's always included. You can't change your sex biologically. Race is a factor. Family history, we were just chatting a little bit, Jennifer and I, before this session, and family history roughly doubles your risk of a cardiac event, regardless of any other factors. If you've had a pre-existing cardiovascular disease, such as a heart attack or a stroke, you can't walk that back in time. Erectile dysfunction is something that is a risk factor, so to speak. It indicates endothelial dysfunction. Sleep apnea may be a risk factor in the sense that some people, if they lose weight, the sleep apnea will resolve. So I think that could be in the category below. In terms of modifiable risk factors, and this is going to be the focus of today's talk, tobacco use, number one, hypertension, hyperlipidemia, obesity and metabolic syndrome, and we'll define that in a little bit. Eat what we eat qualitatively as well as how much. Diabetes, inflammation, often measured by C-reactive protein, activity level, and we, as we'll talk about, even minimal physical activity lowers your risk, and up to a degree, the more you do, the better. And then there are psychological factors such as stress and depression, which are harder to quantitate. And you can get a general idea as to the 10-year risk of events with an app that you can download, that you put in the patient's sex, age, race, total cholesterol, their HDL. And HDL is interesting. I hear repeatedly, and certainly was the way I was taught, that HDL was preventive. But it's important to realize that HDL above 80 actually is associated with a progressively increased incidence of cardiovascular disease. This is sort of a newer concept, and I think what happened is in the early studies, they mainly looked at people who had a cholesterol that was increasing up to 80, but as we've seen, as we've increased our database and we look at people with an HDL over 80, we see an increasing incidence of heart disease. So I think that that's something that will get more attention over the next couple of years. Blood pressure, both systolic and diastolic. Your LDL, which is, quote, the bad cholesterol. Blood pressure treatment status. So even if your blood pressure is treated, that is a risk factor. Diabetes, tobacco abuse, statin use, aspirin use. Those all come into use of the calculators. Next slide. And it's important to realize that calculator gives you a 10-year risk, but one of the things that more and more people are talking about, not 10-year risk, but lifetime risk. So imagine, a 30-year-old with a fairly low 10-year risk. What's that person's risk over their lifetime? Obviously, someone who's 60 or 70 or 80, the calculator, since age is such an important variable in risk factor stratification, that person's 10-year risk de facto is going to be much higher. But the number of meaningful years is less as we get older. So I think looking at things more holistically, although we use a 10-year risk calculator, I think that, for example, if someone has an intermediate risk and they're relatively young, you're going to be more aggressive than if they have an intermediate risk and they're 80 or 90 years old. All right, let's take the first risk factor, and people are very familiar with this one, and it's smoking. And my experience is that the younger someone is when they start smoking, the harder it is for them to quit. So someone who starts smoking when they're a teenager, that's a lot harder than if they started smoking in their late 20s or 30s to get them to quit. Basically, 1 pack a day increases your risk 2 to 3-fold, and the more you smoke over that, the greater the risk of an event, and the greater the risk of the intensity in events, meaning death. So getting people to quit smoking is important. And I think with a lot of the things that we're going to be talking about today, I think one of the questions to ask people is, are you interested in, are you ready to quit smoking, or are you ready to do something about it? If a patient says to you, yeah, I'm a smoker, but I have no interest in quitting smoking, then I think you're finished in that discussion. I think we often waste a lot of our time talking to patients about quitting and changing their lifestyle when they're not necessarily ready to. I think part of what we're trying to do is to educate patients first about why it might be important for them to quit smoking or lose weight or change their diet. But if a patient is not ready, willing, and able to, or ready and willing to change, I think that discussing it in detail, how they're going to do it, I think is not a good use of your time or their time. So some of the things that have been used, and some of these interventions are beyond the scope of what we're going to be talking about today. But people have used nicotine patches and lozenges as a way of getting people away from the hand-mouth habit of smoking. I mean, nicotine is still the addictive substance, but part of the addiction is the circumstances under which people smoke. So some people smoke mainly when they're stressed or after a meal or after sexual intercourse. So the patches and the lozenges and the inhaler and the gum and the nasal spray basically are a way of satisfying that nicotine addiction without the behavioral aspects. 2 other drugs that have been used are the bupropion and the varenicline. And I think that there's no one that's superior. I think with a lot of these suggestions about getting people to change their lifestyle, a lot of it has to do with patient preference. So I've had patients say to me, for example, I'd rather just quit, or I'd rather just decrease my cigarettes by 1 cigarette a week or something like that. So I don't know. I think that taking into consideration a patient's preference about if they're so inclined to quit, what might help them. And often patients say, well, I've tried this, I've tried that. So it gives you a chance to then say, well, what about, and then fill in the blank, what are some of the other things you can think of that might help that patient? Next slide. So the next thing is high blood pressure. And this is a very significant risk factor. It affects 20% of the population, but only about 25% of those people are receiving adequate treatment. So about 4% of people are actually getting adequate treatment. An adequate treatment is that 70% or more of the blood pressures are less than 130/80, as determined by an ambulatory blood pressure monitor. So a single elevated blood pressure, I mean, if you think about it, even if you don't have high blood pressure, when you exercise or you're under extreme stress or have pain, you're going to have some recordings, some numbers that are high. That doesn't mean you have high blood pressure. High blood pressure means on several recordings, under basal circumstances, your blood pressure is elevated. So part of it, and we'll talk about it, is about lifestyle. And that's usually the first thing. And we'll talk about that in just a minute. And for those people who don't respond to lifestyle changes, then that's where drugs come into play, and finding a combination of medicines that are affordable, that don't have side effects, that are effective, and having patients stick with it is so important. Even borderline blood pressure, so 130/140 or 80/90, increases, basically doubles your risk of cardiovascular disease. So 1 pack of smoking will double your risk, having a family history doubles your risk, and having even borderline hypertension doubles your risk. The guidelines for what to treat have changed over time. Usually the goal is less than 130/80. The benefit has to do with what the person's other cardiovascular risk factors are. So the more risk factors, the greater the benefit of treating the blood pressure. And this is true in a lot of things in cardiology. It's easier to see a benefit if the risk is high. It's harder to see the benefit as the risk is low. And obviously the risk is highest if someone has other additional risk factors. So if you have someone who's a smoking hypertensive, that's more important to lower the blood pressure in that patient than it is in someone whose only risk factor is high blood pressure. So we start the first thing to start with in someone who has borderline or mildly elevated blood pressure is what's called the DASH diet. And that's the dietary approach to stop hypertension. That's what DASH stands for. And we'll talk about that in a minute, but that diet is very similar to the Mediterranean diet, which is very similar to diets that you see. So if you read articles about increasing longevity, which is a hot topic these days, particularly where I am in Silicon Valley, where people, for reasons that are unclear to me, want to live to be 120 or 140, it's very similar. It's basically fruits, vegetables, whole grains, low-fat or non-fat dairy products, fish and poultry, and avoiding meat, full-fat dairy products, sugar, and sodium over 2,000 milligrams a day. And I would add to that processed foods, and we'll talk about that. And I think, when patients go to a store, they don't buy saturated fat or unsaturated fat. They buy food. And so I think focusing on foods that people get, whole foods, rather than focusing, as we're often taught, about how much salt is in it or how much saturated fat is better. And I think the idea that that food is something your grandmother would recognize as food. So an apple or asparagus, that's food. A bar or something that's processed is not food. That's something that your grandmother would recognize. And I think the more you stick with recognizable food and that look like food and taste like food, the healthier it is. I think the other thing that helps with blood pressure is regular exercise, and we'll talk about that in a minute, as well as weight loss. So I remember there was someone who I went to medical school with who had blood pressure problems, and literally you could tell whether his blood pressure was good or not by looking at him. When he gained weight, his blood pressure went up. When he lost weight, his blood pressure came down. And quite honestly, the only way you know if someone's blood pressure will improve with weight loss is for them to lose weight. There's just because someone's overweight doesn't mean necessarily that losing the weight will drop their blood pressure. And my observation is that the longer someone is overweight, the less likely it is that the weight loss will make a meaningful difference. But I think it's worth an attempt, particularly with someone early on. So the key to treatment is the blood pressure control rather than the agent used, other than in very specific situations. So it's less important whether you use a diuretic or an ACE inhibitor or a calcium blocker to get the person down than it is to make sure that their blood pressure is controlled. Now, there are circumstances where, what the person's comorbidities are determine what drugs you use. So, for example, with early chronic kidney disease, one tends to use ACE inhibitors and ARBs. If someone is Black, for example, we usually avoid those and beta blockers. I think the other thing is, particularly with older patients and particularly people who come in with white coat hypertension, that is, their blood pressure is higher when they come in to see us, is not to overtreat them, because sometimes what happens is they come in to see us, their blood pressure is high, we give them drugs, they go home, they're no longer so anxious, and their blood pressure is actually low, and they have low blood pressure, and they pass out and they injure themselves. And this is more of a problem in elderly patients. So home recordings are important, and checking things posturally when they come in to see you. And to go slow, the older someone is, I think the more important it is to gradually increase their blood pressure regimen. Next slide. So what about diet? And the only diet that has been shown to lower cardiovascular risk, other than the Ornish and Pritikin diets, which may date me a little bit, those are very low in fat. In fact, I remember my father-in-law was on the Pritikin diet, and I think he said that eating that diet was like going out in the backyard and grazing. The Mediterranean diet, the nice thing about it is palatable, and patients will stick with things that taste good. So instead of us focusing as providers on what patients should be eating, we should be focusing on what patients can eat. So, what fruits do the patients like? What vegetables do they like? Whole grains rather than processed grains. Fish, as I mentioned, low or non-fat dairy, lean poultry, nuts, beans, legumes, non-tropical vegetables. So you should avoid palm and coconut oil, which are, and basically focus on things that are oils that are high in omega-3 fatty acids. And if we're using these to cook, a high smoke point, which means, so what happens is if you use oil in your cooking and you're cooking at very high temperatures, that causes the oil to oxidize, and you've now made something that's healthy unhealthy. So olive oil and sunflower oil both have high smoke points, and you can Google oils with different smoke points and get an idea. And this is probably one reason why consumption of olive oil is felt to be positive. Alcohol. So, we know that alcohol in excess is bad for not just heart disease, but a lot of other things. So I think moderating what people have to 1 to 2 drinks a day, and I think it also depends on, we say 2 drinks a day, what you're saying is, something that's 2 ounces of alcohol a day, a little bit more of wine versus hard alcohol. So drinks are kind of could be a subjective thing, but I think that the point is that excessive alcohol should be avoided. And we talked about focusing on what you can eat, but I think the things that people should avoid are saturated fat, which are mainly meat and certain, as I noted above, non-tropical vegetable oils. You should restrict your sodium. You know, there's been a lot of buzz in the medical literature recently about the fact that a lot of people with heart disease are getting too much salt. And salt is a problem both for people who have high blood pressure as well as people who have problems with heart failure. So I think restricting it, and they should, you know, what I used to tell people, you know, soy sauce is salt sauce, so soy sauce is not a way of doing it, but they can use other seasonings. I tell people they shouldn't use a salt shaker on the table. They may use a little bit of salt in their cooking, but you can other things, and you know, even if a recipe calls for a certain amount of salt, they can use less or none. Sweets. So in the 50s, there was a battle between the fat lobby and the sugar lobby, and the fat lobby lost. But we know, you know, I would say roughly half of our patients with heart disease have a cholesterol problem, but the other half are people who are either pre-diabetic or diabetic. And so when we say don't eat fats, that only leaves two other food groups, protein and carbohydrates. And there's good and bad carbohydrates. The good carbohydrates are, we talked about those that are high in fiber and are unprocessed, but things that are sweet, both, you know, glucose, fructose, high glycemic foods, which are the whites, pasta, white bread, potato, and rice are easy for me to remember, should be avoided because they're quickly broken down into sugar. And so, you know, back in the day when we were very restrictive about people's cholesterol and fat intake, people would eat a lot of pasta. They would gain weight. That would make their pre-diabetes overt or their diabetes overt, and then they were significantly at risk for heart disease. So that's not a good strategy. Calories from fat should be less than about 5 or 6%. Lastly, there's some meta-analysis that suggests there's a benefit to taking exogenous N3 fatty acids, but you know, so you know, these fatty acids are found in fish. We as clinicians tend to try to figure out, okay, what's healthy about eating fish? And I think it's better just to eat fish than to take a supplement. There are some people who don't like fish, so that's a problem. But I think if someone doesn't like fish and they want to get the benefits, that's one option, but it's not quite as good as eating fish, I don't think. Folic acid and coenzyme Q10 seem to be of some benefit, whereas beta carotene and calcium supplements actually increase risk. Next slide. So what about LDL or bad cholesterol? And, you know, it's interesting. I would say, you know, there are some people whose cholesterol's high because of their diet, and there's some people in whom their cholesterol's high because of their genes, or it's some combination of those two. And the only way to know how much of someone's high cholesterol is dietary versus genetic is to have them follow a low cholesterol diet. So if someone's cholesterol is 300 and you put them on a low cholesterol diet, the next time you check it, it's 150. It's like, well, you have your answer. On the other hand, if they go on a low cholesterol diet and their cholesterol is still 300, then you know you have the answer also, in that really the problem is genetic. So you never know from the phenotype, from the expression and just the number. But if someone has a problem with their diet, obviously that's something they have to stick with. If the problem is more metabolic and genetic, then they have to stick with their statins. So basically, there's a linear relationship between bad cholesterol, LDL, and coronary heart disease risk. And interventional studies show that for every percent decrease in that, there is a 1% decrease in coronary heart disease risk, including heart attack, stroke, death, and need for revascularization. So statins not only lower the risk of heart disease, but also of stroke. And also, this is a drug drugs for which I think people who have peripheral vascular disease should be on. People typically don't die of their peripheral vascular disease, but since 75% of people with peripheral vascular disease also have atherosclerosis involving the heart, you're treating and preventing heart problems in those patients in whom peripheral vascular disease is a marker for atherosclerosis. So there's a statement here: statins may be cost effective in primary prevention if the risk is higher than borderline. So there's 4 categories of risk. Less than 5% is low risk. And this is based on the 10-year risk calculation that we talked about from the calculator. 5 to 7.5% is considered to be borderline. So I think in people who have borderline risk, statins may be cost effective, may or may not be. And we'll talk about that there are other things that you might want to do to sort of risk stratify them better. For example, if someone has a risk of 5 to 7.5%, but they have a family history, let's double that. And now that clearly puts them in a range that you would want to treat them. 7.5 to 20% is intermediate risk, and over 20% in 10 years is considered to be high risk. So it's 5. Less than 5% is low. 5 to 7.5% is borderline. 7.5 to 20 is intermediate, and greater than 20% is high. And your target LDL depends on your risk and whether it's primary or secondary prevention. So primary prevention is less than 100. If it's secondary prevention, it's less than 70. The drugs that are used now to lower the cholesterol include statins. And if they don't come down with that, we add ezetimibe. And if those drugs are not effective, we add a PCSK9 inhibitor. And those drugs are particularly helpful in people with familial hypercholesterolemia and secondary prevention. There's a new drug that requires an injection twice a year called inclisiran, which also affects PCSK9. And then bempedoic acid. And I'll just say that for the inclisiran, there's, to my knowledge, no evidence. It lowers cholesterol, but there's not yet evidence that it lowers risk. So we use cholesterol as what we call it's a surrogate marker. We assume if we lower someone's cholesterol, that it'll lower risk. But basically, a patient doesn't care about their cholesterol. They care about whether they have angina or heart attack or get a stent. So although it's important to know that new drugs that come out lower cholesterol, what many clinicians are looking for is not that they just lower cholesterol, but they lower risk. And obviously, it takes longer for those studies to be done than just seeing whether they lower the cholesterol. So you'll see a lot of studies in which initially showing, a drug has promise because it lowers cholesterol, but often before insurance will pay for it or becomes standard of care, we want to see that the drug also lowers the risk. Next slide. And this is just a little bit more about LDL lowering. And this is, there are newer guidelines in 2018, but it talks about the different bins that we put patients in. So for example, bullet point number 1 has to do with the fact that the people who, basically almost everyone who is secondary prevention who's had an event should be on statins. Number 2, people with significant hyperlipidemia, even if it's primary prevention, should be on statins. Number 3, if they're diabetic. So diabetes is a risk factor for heart disease that's what's called a coronary artery disease equivalent, which means that if you're diabetic over 10 years, your risk of a heart attack is similar to someone who's already had a heart attack. So that's why people are treating virtually every diabetic, unless their LDL is less than 70, with a statin. And lastly, primary prevention. So these are people who don't have a problem, never have had an event, but the risk calculator shows that their 10-year risk is greater than 7.5%. And I think the way that I would use a risk enhancer that we'll talk about in a minute, particularly calcium scoring, the CAC is a coronary artery calcification score, is in primary prevention. Someone has a high cholesterol, but based on whatever reason, they're very reluctant to take a statin. And if you think about it, cholesterol is just a blood marker. It doesn't, some people with a high cholesterol will get disease and some people won't. If someone has a significant coronary artery calcium score that's higher than the 75th percentile for age, that means they have disease in the arteries. Normal coronary arteries do not have any calcium in them. So taking a statin for someone who has a significant coronary artery calcification is not treating a number, it's treating disease. And I think that often will assist patients as well as doctors to make a determination that someone needs to be on a statin. So if you have a 40-year-old who has a high cholesterol and a family history, the cholesterol may not be all that elevated, but they have a family history, you get a calcium score and it's significant, that is something, since you can't change the person's genes, you can change their cholesterol, that often is the impetus for putting someone on a statin. So what are some of the risk enhancers? And those are the things that suggest that despite that aren't necessarily included in the calculator, but put someone at increased risk. Well, one is a family history of premature heart disease, which we talked about, which roughly doubles the risk of coronary disease. A C-reactive protein, which is indicative of inflammation greater than 2. And what we're learning is that some people have a high cholesterol, which gets oxidized, which causes an inflammatory response. But some people just have inflammation. And as we'll talk about, this is something, even in people who've had their cholesterol lowered, if their C-reactive protein is still significantly elevated, they're still at significant risk. So markers for inflammation, if they have no other cause. So, if someone has another inflammatory disease and that elevates their C-reactive protein, that may invalidate it as a marker for general inflammation, although as we'll say a little bit lower, chronic inflammatory diseases like rheumatoid do increase the risk of coronary artery disease. So that's a risk enhancer. An ankle brachial index less than 0.9, so that would be indicative of some degree of peripheral vascular disease, which often is asymptomatic. Ethnicity, for example, if someone is Black, a coronary artery calcification greater than the 75th percentile for age. Little p little a has been discussed extensively recently, and we know the higher the little p little a, the greater the risk of coronary disease. There are studies that are ongoing now that should give us an answer in the next couple of years as to whether lowering the little p little a lowers the risk. So the question is little p little a just associated with an increased risk, or is it causal? And this is one of the great challenges for us as clinicians, what's associated and what's causal. The only way you know if something is causal is if you lower it and it lowers the risk. So there are a number of drugs now that significantly lower little p little a. We know that. The question is, do they lower the risk? And we should have an answer to that shortly. But I would say that if someone has an elevated little p little a and their LDL is even, is elevated and either in the borderline or intermediate range, that would be something that would make me want to treat someone and would be a risk enhancer. The metabolic syndrome, which we'll define shortly, is another thing, because people with the metabolic syndrome do have an increased risk of heart disease. If they have chronic kidney disease, we talked about chronic inflammation. Also, if it's a woman and she's had premature menopause or preeclampsia, those people are at increased risk of cardiovascular events later in life. And getting back to the idea that lowering cholesterol doesn't necessarily lower risk, studies have not shown any benefit in terms of lowering risk for either niacin or fibrates. Next slide. So let's get into the problem now of obesity, metabolic syndrome, and diabetes, which is now an epidemic in the United States. Diabetes and prediabetes are defined now by both fasting blood sugar and hemoglobin A1C. I mentioned that diabetes is a coronary artery disease equivalent, meaning that over 10 years, someone who's diabetic has the same risk of a heart attack as someone who's already had one. And it is occurring, when I made this slide, 1 in 12 people in the United States, it may be even higher than that now. And type 2 diabetes is a disease of insulin resistance, and maybe maybe a prodrome. Insulin resistance is also part of the metabolic syndrome. And to have the metabolic syndrome, all you need is 3 out of the 5 criteria. So one is obesity, number 1. So for a man, if your waist is greater than 40 inches, or you're a female, waist greater than 35 inches. Number 2, a low HDL. For a man, less than 40, a woman, less than 50. Triglycerides, greater than 150. Number 4, insulin resistance, either prediabetes or diabetes. And lastly, hypertension or on antihypertensive treatment. So, important thing to realize is that the risk, as well as some of the other associated things associated with the metabolic syndrome, can be reversed with weight loss. And this may be either by someone eating less, although one of the problems with just weight loss, as we've learned, is that people who gain weight, they not only have as they lose weight, what happens is their metabolism slows and their body has established a new set point for what it considers to be an ideal weight. So someone, for example, they may lose weight from 200 to 180. And then if their body has said, oh, 180 is the new set point, losing weight below 180 may be a real challenge. And this is where the new drugs come into play, as well as gastric surgery. So gastric bypass surgery lowers the weight more than 15%. The SGLT2 inhibitors and GLP-1 receptor antagonists help people lose weight. And, other than the expense, one of the knocks against, in particular, the GLP-1 receptor antagonists like semaglutide is that when people stop the drug, they gain the weight. And I would just say that you don't know in advance exactly what will happen when you stop the drugs. Some people, you can stop the drugs and they maintain the weight loss. And some people, you need a lower dose. And in some people, they need to be on the medicine indefinitely. And initially, this was a big negative to me. But when you realize that if you think of obesity as a chronic disease like hypertension or hyperlipidemia, and that people take lifelong medicine for it, it becomes less of a barrier. And what I'm hoping is over the next couple of years, we'll move from injectables to orals and from expensive to less expensive medication. So I think that these drugs are incredibly potent in that studies have shown that patients often lose up to 15% of their body mass. But the cost and the fact that they are injectables is a significant barrier to their use. And then exercising certainly assists, if not in weight, in improving insulin sensitivity. Next slide. So what's recommended in terms of exercise? I think ideally 30 to 40 minutes, 4 to 5 times a week, but basically anything someone does. So if someone is sitting in a chair in an office all day long, and you can get them to stand and walk around, we know that a sedentary lifestyle is as bad for your health as smoking a pack of cigarettes a day. So anything you can do to motivate a patient, and you know, it's fascinating to me. Just some people love exercise, and some people it's an anathema; they hate it. So I think people get discouraged, the patients get discouraged, doctors get discouraged because patients can't necessarily have the time or the interest to exercise as much as we would like them to. But whatever you can get a patient to do in terms of physical activity is a plus and lowers their risk. And if you think about it, exercise can help with obesity and metabolic syndrome by increasing insulin sensitivity. It helps with diabetes. I have my grandson is a type 1 diabetic, and I played sports with him, and his sugar went from 180 down to 60. So it definitely does have a significant effect on insulin resistance. Hypertension. So people who start exercising, often just doing exercise on a regular basis can help some people's blood pressure. In some people, it helps cholesterol, although I would say, in my experience, much less of an effect. And lastly, inflammation. And then one last slide, I think. And this has to do, two more. So antithrombotics. So what is the role of aspirin in primary prevention? And I would say these days, very little. It's basically for people, males over 45 and females over 55, if they have significant cardiovascular risk and if their bleeding risk is less than their cardiovascular risk. And this actually applies to a fairly small number of people. We used to give aspirin fairly routinely, but in retrospect, the bleeding risk was greater than the cardiovascular risk. We know that clopidogrel is associated with lower bleeding than aspirin. It's equivalent to aspirin in terms of ischemic prevention, but it's a higher cost. So most people use aspirin unless they're allergic to it or can't take it. And we know that rivaroxaban, which is a DOAC, it's a direct oral anticoagulant, is helpful in secondary prevention in acute coronary syndromes and peripheral vascular disease. And now the last slide. And that is, we talked about inflammation. And one of the things that highlights the significance of inflammation is that colchicine has been approved by the FDA for secondary prevention, and people prevent with an acute coronary syndrome. And acute coronary syndrome is thought to be due to a inflamed plaque, which ruptures and causes a non-obstructive clot. And colchicine has been approved for those people. Next slide. So any questions about disease prevention? I think it's a real challenge. I think that, it gets to this whole issue of nature versus nurture. We can't really affect people's genetics, but we can affect the environment that they put their body in. And that's our goal as physicians, is to keep people healthy. And we should be focused on health and not just disease. So any questions? I don't see anything coming through.
Yeah, we have one question that was
Good.
submitted right about when you started the presentation. Does premature stroke at age 62 without risk factors contribute to a family history of cardiovascular history?
It's not noted to be. So when they're talking about a premature cardiovascular disease, they're talking about heart attack. There's three types of stroke. There's ischemic, there's hemorrhagic, and then there's embolic. And only an ischemic stroke would necessarily be, due to atherosclerosis of the cerebral blood vessels. So it's not considered to be a family history of premature heart disease at present. Any other questions? So I thank you all for your time and your patience and your focus. And it's a real challenge to get patients to change their lifestyle. And I think it all starts with educating our patients as to the importance of risk factor modification and not being fatalist about things. And I think you can spin it any way you want to in terms of, maybe you want to live longer. Maybe you want to enjoy the quality of life. So it's a quality as well as a quantity of life issue. But until the patient in front of you is, ready to make these changes, I think all we can do is educate them. And when they're ready, then I think we want to take the next step as to letting them know what they can do to lower their risk. So thank you. I do see, is there a question here? Let's see.
There is a question. When using a CV risk calculator, the value that can be entered for each GL cannot exceed 100. With the change in thinking about each GL, the calculation may be flawed now, giving you a false low risk in someone with a very high HDL.
Yeah, I would agree with that. I think, we're often, especially in women, lulled into a false sense of complacency when we see an HDL of 120. I think the risk calculators were initially developed before there was a big database of people who had an HDL that was very high. So to me, a very high HDL would be another one of those risk enhancers and would make me lean a little bit more toward treatment rather than against treatment.
And then a couple other questions. If a patient is able to lose weight and get off of diabetes and hypertensive meds, would they still be advised to take statins?
Statins, yeah. So I think if someone loses weight and they're no longer a diabetic or pre-diabetic and their blood pressure goes away, then I think then I would recalculate their score. And so whether they stay on a statin depends on their LDL still, and depends on their age and the other things that they're listed there. But the likelihood is that a significant number of people who lose weight and their blood pressure comes down and their diabetes resolves will be able to come off their statins as well. But you have to redo the risk calculation. It's not a static thing that you do once, set it and forget it. I think you then have to redo it. The next question here is, where's a good place to get a calcium score? So I'm not sure where you are, so I can't tell you specifically. What I can tell you is a calcium score does not require an IV, does not require any kind of an infusion like it does for a CT angiogram. They're typically done in any place that has an ultra-fast CT. They're usually done at most hospitals that have a CT. There probably are cardiologists or other places in your vicinity that have an ultra-fast CT. It's a fairly inexpensive test. I would say, $50, $100, $150 would usually be how much it costs. Some insurances cover it, some do not. But I find it an extremely helpful test because, as I mentioned, you have someone who's reluctant to take a statin, and this shows that, you know, the cholesterol is not just a number, but they may or may not have disease. Now, if I have someone who has a high cholesterol, which according to the calculator, it would put the person in a risk in which they should be on a statin, and their calcium score is 0, I would not put them on a statin, although I might repeat the calcium score in 5 years. Did someone have a follow-up question? I saw briefly there was something there about a follow-up question about HDL.
Yeah, I think they were just writing that underneath the other question that they had asked.
Okay, I'm open to any other questions.
Okay, well, while they're thinking about any other questions, we still have a lot of people on the call. I did put it in the chat. Again, just a reminder about the CME survey. It's
Oh,
just
there
a
we go.
it's just a reminder that, oh, I'm sorry. Oh, we have somebody with their hand up.
Okay, good.
Okay, let me allow to talk. Okay. You can unmute yourself and talk, Dr. Shamkhani.
I ended up typing the question. Never mind.
Oh, okay.
Sorry.
Okay, well, thank you for being here and for asking a question.
Oh, sorry about that.
And welcome to MAVEN also.
Okay, sorry. Yeah.